brief is really very narrow. I'm here to talk about the Dementia Intelligence Network, which is really dry. I'm going to try to make it less dry. And at the end, I'm going to do what I normally do, which is completely ignore my brief and try to answer some questions which I think are the questions that need answering at the moment, which is, of course, nothing to do and everything to do with the Dementia Intelligence Network. But I'll come to that. So basically, what is this network? This is the slide which I got from the team at Public Health England, and it's really interesting because Public Health England is a whole group of organisations and scientists which covers enormous remit. And I said, let's try to have a talk which doesn't have very much jargon and actually deals directly with people. And you can see what the result of that is. This is not a joke. I'm not trying to emulate Alistair in that. We work very closely together because we're so different, and that I think is really quite important. A, that we work closely, and that is relatively unusual considering we come from very different worlds. And secondly, the fact we understand that we're so different and actually use each other for that reason. But this is typical because this is a scientific discussion, two scientists. These are all the leadership groups. There's so many bodies, so many organizations that it's no surprise that you're getting the questions from the floor, which Angela got in terms of, you know, why can't organizations work better together? Look at the challenge to get all that lot to work together. Also considering that a lot of them are completely separate from each other. But health and care is very complicated. Even Mr. Trump knows that. He even said it. And, you know, it really underlies the complexity of the situation we have at the moment. Having said that, there are some solutions. That's what I want to talk about at the end. It's not to do with the network, but it's actually what I think I should say today. So the network itself actually produces a lot of data profiling tools, as well as reports and briefings, scientific, for the system, for the carers, to actually help the carers and help the system actually change what they're doing and doing perhaps something more important for the individuals. So the Intelligence Network is hosted by Public Health England. It aligns to various other pathways, some from the OECD. It aligns with some our colleagues from the National Institute of Clinical Excellence. And it works with all the different bits in terms of healthcare, from the Department of Health. And you notice there's something really important missing from there, from working with all system partners. You know, the people are completely missing from there, as you can see. It works with centres, it works with the DH, it works with NHS England, it works with charitable sector, academics, and you, local authorities. Absolutely, you're quite right. Even though some of its outputs can be used by local authorities, but you know, the thinking, we're not quite there yet in the way we think. I don't need to show this. This is really what the challenge is of the 2020 commitments, what we have to do. But clearly we needed to have a place to help the system change, whereby what the system was doing was reflected back to it in a way which was which made sense to it. And what I'm hoping you will be able to see is this process and this system that we have developed is something which you as the people, me as the people, can use to actually assess how well our systems are working in the places we live in, to be able to provide reasonable challenge to the people who are providing care to us, be they from health or social care, in terms of the care we're receiving ourselves, because we can compare ourselves to other places very, very easily. So this is the network itself. It was set up in 2014, and it does all sorts of stuff with all sorts of different people. I don't think that's particularly relevant, but this is probably more important. And it shows all these profiling tools which are available. But getting down to what this is about and what it's there to help a person do. I think understanding the needs of your local area. And remember, this is really faced and designed for the health and local government systems. It enables the systems to understand where they are compared to other places. I would suggest it helps the people understand where they are, where their local system is compared to other places. And I think that's really quite important, because this is very easy to access. And more importantly, you don't need to sign up, you don't need to do anything. All you need is accessing it, placing where you live, and from there it follows on. And I'll explain how you can get there. Those were the intentions we had when we set it up. Best value for money, where are our target areas, what's the scale of the problem in the area, and remember, this is for the organizations that deliver care. And this is what it's made up of. And these are the different domains. But it's actually, as Alistair said earlier, it's actually quite simple. It covers the whole journey around dementia and living with dementia, from understanding how many people there are within an area, how well the organizations are doing at managing risks for the people, how well they're diagnosing the condition, how well people are being supported and living within that area. And I'll go into each of these in some detail to really give you some sense of what is being measured and why it's being measured. And finally, of course, to dying well. In terms of where the questions have come, in terms of what we need to do better, everyone that we speak to from the health and care systems always wants a somewhat different geography, inevitably, always wants some more customization of the metrics, inevitably, and always wants some more easier way to actually identify trends and project them. But that's no surprise. But what we're trying to work on at the moment is really to get age in a little bit more than we have, and also to actually try to start to manage that inequalities issues. We know that people from there is a sexual issue with dementia, in terms of more women tend to get dementia than men. We know that people from ethnic communities tend to get more dementia than others, and those metrics are not incorporated within our fingertips profiles, and that's partly because we've never collected them till now. And by we, I mean the health system has never collected them. And for that reason, it's taken some time for us to start to be able to develop that. The next real push is going to be around the Black and ethnic communities being measured better. And we now, at last, are starting to collect ethnicity of individuals to be able to use that and reflect that back. So the only thing, if you remember one thing, it's the bottom strap line, because you'll be able to find where you are in England if you go onto that website. That's it. And from there, everything else follows. You'll be able to start to describe prevalence, preventing, diagnosing, living. You see the lines down, going down from the top on the left. So from there, I think you start to get a feel of where you are. And clearly, if we don't measure where we are, we can't hope to improve, because everyone can say they're doing the best they can, and we won't know how well people are doing, so we can't compare ourselves. So, I mean, the transparency is at the heart of everything we do. We fought a fight to make sure this was also open to people rather than behind firewalls. So this is there not only for the system to compare itself, I would suggest it's there for the people. For the people to see how well their local area is doing, and to challenge their local area in places where it's not doing as well, and to celebrate their local area in places where they are doing well. Because in some places there is fantastic care, and in some places there is not fantastic care. So let's have a little look at. Let's start with the prevalence. These are the indicators that we use to look at prevalence. And we are limited to a degree by what has been collected in the past, because of course, to start to reflect this, the data needs to be collected to start with. So we are limited to what what is feasible and possible. All we have done with this network is actually bring all that data together in a place whereby it is manipulatable by the individuals to actually help them to plan their services better in terms of health and care systems, but I would suggest also for people to be able to see where they are in their system. And, by reflecting that in a map, which you can do very easily from the fingertips, in the fingertips portal, you'll be able to see how your area compares with other places. For example, why does the Northeast seem to have a higher recorded prevalence of dementia? You can start to ask those questions. If we move to preventing well, and this is a world where we have spent, certainly within Public Health England, we've spent an awful lot of time trying to get the concept of dementia understood in a different way from the very, very narrow Western medicine type approach of deciding that people were either had either Alzheimer's or vascular, and the condition could be only considered on its own, to us understanding that all these things are interrelated. And you're much more likely to develop dementia if you have obesity in your middle years. You are much more likely if you have hypertension, if you have diabetes, obviously if you have stroke, depression. So we measure all of these because clearly if we manage all of these factors in people, the likelihood is we will see a reduction in the number of people who will be living with dementia. And in the absence of a magic bullet, which we haven't got, clearly what we need to do is manage those better to be able to have a much fuller and enhanced life. And that's certainly the aspiration of all of us. So we can actually quite easily compare two areas, and there's a demonstration of that here, where Sunderland and Durham and Sedgefield are directly compared to each other. And you can see where the problems potentially are within the different areas. You can see where the services seem to be working and seem not to be working quite as well. And I think that really helps, because if you have, as local government, if you're thinking in terms of where I'm going to put my money, and you have a particular problem in obesity in one area and less of a problem, surely it makes more sense to actually spend the money in obesity services in the area which has a higher, that you get more bangs for your buck. So this can be helpful for organizations. And there you see an example of that being used in practice. This all comes from fingertips, nothing more than that. In terms of diagnosing, it was really difficult to try to get the best indicators for this, but we used an amalgam of blood test recording, which means that clinicians were actually taking the tests to try to diagnose the condition. And again, we have the usual variation. You inevitably are going to get variation in systems. I think we all understand that. But in England, we still have an unacceptable level of variation between different places, which is unexplained really by the demography which people are dealing with. So we still have a lot of difference in the way that clinical practice is actually being managed in those areas. And Alistair's task, and I help him in that, of course, is around trying to change that, to get a much more evidence-based, human way to deliver care. And I know we don't do it as well as we perhaps should do it by this time, because perhaps we could have been a little bit closer to getting to the state where we all felt more comfortable with the care we're getting. This is living well. We know the issue now of social isolation is particularly more important than we thought a few years ago. We know that the effect of social isolation on people at retirement is equivalent to them taking up smoking, for example. And I am not advocating people taking up smoking, by the way, before I'm misquoted. But the actual effects of that upon somebody's life, of being socially isolated, which so often happens the moment somebody retires, is really, really very significant, as well as, of course, the effect of that upon carers, because carers have perhaps inadvertently been not quite as well represented in the thinking of us designing services for people living with dementia. And I love the change of the I statements to we statements, because the we statements, I think, encapsulates the fact that dementia is not only a disease which affects people, but also affects people and the people around them. So at last that is acknowledged, I think overdue, but at least we've got there. And we've also started to think in terms of carer-reported quality of life scores for people caring for someone with dementia. That is really, really important, because I think that is the start of a process which will start to get alignment of our systems to what people require. You notice, carer-reported quality of life scores means the people who are actually judging the system are the carers. Now, the moment we start having people judge a system, and that being part of the metric which is responsible for driving a health system, we're going to get the congruence, which is going to stop health systems thinking in terms of managing disease and people thinking of managing life. So that is really, really important. And that's the start of something, and there's more of that coming. So I am more hopeful. I've been fighting to get that as the thing which drives health and care for the last 30 years. So it may not seem like a lot, but I think it's a lot. Again, trends allow us to see where we are, where we're going, whether we're getting worse or whether we're getting better. As also comparing ourselves to where we were, and also comparing ourselves to our peers in terms of other areas which we think are sort of similar in terms of the demography and the people who live there. And these are the metrics we used for supporting well. And you can see what they are. They speak for themselves. And again, we can benchmark, we can compare areas with other areas. We can talk about variances being outside. If you notice, there are little. If you notice, any of those lines ends up with a long grey line, a darker grey line in the middle, which is the confidence interval, and the little red line, which is sort of the average. And so you get where an individual organization is, some of them are within what one would expect is the normal variation, so it doesn't necessarily mean very much. But there are some which are sort of outside of that, and the moment they're outside of that, it means, this is statistically significant, this variance. So there is something that should really be done to actually move that into the right area. Of course, as long as it's not getting better, then you don't want to move it backwards. And dying well. Again, these are the metrics which we're using to measure that. And you can also ask questions like, are these people, are people who are dying well at home? We think it's important to be able to die at home if one wishes to die at home, because most people say they wish to die at home. Is it associated with them being in a care home that people die at home? In other words, are we fooling ourselves by saying, even though a care home, of course, is people's homes, but are we really enabling people to die at home as much as we should do? So that's really what's behind this slide. So this is really where the Dementia Intelligence Network is going to be working quite a bit in the future. Working with WHO, that's really quite important. Working with the Black and ethnic minority groups to get better data on dementia and ethnicity, because we haven't really done very well there. Working with health economics, I spend most of my life working in government, going from department to department and treasury, talking about the importance of dementia. But it's not an easy discussion, especially when one is immediately challenged with return of investment. And I think we need to get better at actually managing that to be able to have some pretty cogent arguments to push back in terms of better life, better disease-free life years. A disease-free life year for somebody is a year whereby they are contributing to the economy. So it's not only about longevity. It really is about living to the maximum extent we wish to at whatever stage of life we are in. And that's what's next. I have to stop. Oh, great. So I won't say what I really wanted to say. And I just wanted to say one thing, and then I'll stop. And it's really how we can change the system. And that's really what all the questions were being asked for. I think there is a solution, and that solution is really making the metrics which drive healthcare very similar to the metrics which drive people. If we get that conjunction, we will then, perhaps for the first time, be thinking and being able to challenge why a system doesn't change quickly enough to really answer some of the questions which came from the second row in particular, much, much better. Because a health system will have it as its interest to be able to do the same thing which people want, which is to live better, to live in a way whereby their needs are respected and not to be discriminated against. Thank you.